start? Let me start. Thank you very much. I would like to acknowledge my co-authors and mentors. We have no disclosures to make. It is a well-known fact that it is a well-known fact that hematolymphoid malignancy are medical conditions. Even though complications such as epidural spinal cord compression can be treated without surgery, as it is ultra radiosensitive tumors. This patient with paraparesis since 2 days, he got radiation, and after MRI, as we see, the tumor has completely melted away within 10 days. Therefore, the NORMS framework recommend that for ultra radiosensitive tumor like myeloma and lymphoma, irrespective of severity of epidural spinal cord compression, they can be treated with radiation as they respond very well. The current international guideline recommendation for ultra radiosensitive tumors, primary treatment with radiation unless there are evidence of frank instability, rapid neurological deterioration, necessitating surgery first. This made us think how many emergency presentation of epidural spinal cord compression that we are operating urgently for neurological deficit turn out to be tumor that are ultra radiosensitive. This is an important question to ask as the surgical intervention carries a high risk of morbidity in emergency setting for these compromised patients, especially in multiple myeloma. We did a retrospective chart review of single institute in which we quantified the incidence of hematolymphoid malignancy presenting as acute epidural spinal cord compression without any prior cancer diagnosis. Secondly, what percentage of these cases could have been treated with radiotherapy if diagnosis could have been made earlier. We did a retrospective chart review from 2009 to 2021. We constituted these parameters, that is metastatic epidural spinal cord compression, presence of neurodeficit, no prior cancer diagnosis or cancer-free period for more than 10 years. Exclusion criteria were neurological, if neurology is intact with pathological fracture, intradural diseases, primary bone tumor, and known prior cancer diagnosis. We studied these parameters mainly which constituted severity and duration of neurological deficit, Bilski grading, staging of visceral mets, sin score, histopathological diagnosis, and neurological outcome and survival status. We found that the thoracic spine is the most common site of metastasis in these patients. And the grade of epidural spinal cord compression in our study was in 36.84%. We found Bilski grade 2. In 63.15%, we found Bilski grade 3. After 19 patients, we found out that 2 patients had stable spine, 47% of the patient has indeterminate spine, and 42% of the patient had unstable spine. The surgical intervention took was posterior decompression in 31% of the patients. In 69% of the patient, posterior decompression plus fixation. In histopathological diagnosis, we found myeloma constituted the majority of the chunk, that is 35%, and 17% were lymphoma, which total constituted 52% of hematolymphoid malignancy of the total cases. We followed the patient for 2 years. In 2 years, we found only 78% of the patient was alive after 2 years also. And ambulatory status, 31% of the patient was non-ambulatory, 57% of the patient able to gain independent ambulation post-surgical intervention. Out of the total hematolymphoid, the patient with hematolymphoid malignancy and stable and intermittent lesion came out to be 8 in number, which constituted 80% of the total hematolymphoid malignancies. So, if surgery is the right call for this patient, can surgery be avoided if diagnosis is made quick enough? We did literature review for this. This paper also found out the quite similar finding in which they found more than 50% of the cases were hematolymphoid in origin. So conclusion, in our series of hematolymphoid is 53% and is the most common pathology in cancer-naive patient presenting in ER with neurological deficit, out of which 42% of the patient of our series surgery can be avoided if the diagnosis could have been made earlier. Obstacle, early histopathological diagnosis in emergency setting is a challenging thing, and a specialized emergency clinical pathway for metastatic epidural spinal cord compression can be developed to target this problem. Thank you.
So I'll call in the next presenter, Dr. Sajeev Shekhar. He'll be presenting dual implant fixation in complex distal femur fracture, special indication and benefits.
Good morning, respected chairpersons, sirs, seniors and my colleagues. On the outside, I'd like to thank my mentor, Dr. Vivek Shetty, sir, for entrusting me with this topic, and Wiroc for giving me this opportunity. I'll be speaking on dual implant fixation in complex distal femoral fractures, the special indications and their benefits. Distal femur fractures more commonly seen in the elderly and the osteoporotic age group, but they are challenging when you want to fix them in a periprosthetic and an obese patient. Most common single implant modalities are either the lateral lock plate and retrograde intramedullary nail. Large meta-analysis of 46 articles have said that there are about 7 to 10% of failures in a single implant fixation. In our world now, do we accept these 10% failures? The failures commonly seen were in the osteoporotic, where there is a medial bone loss comminution, or in periprosthetic situation. Like any fracture, distal femur fracture also has the best outcome with early mobilization and full weight bearing. So the questions arise, do we rely on these single implant fixations for immediate full weight bearing post-op? Do we ask these elderly obese patients to be bed bound or hop around on a walker? Or do we just accept the 10% failures? In our series of 10 patients where at least 2 implants were used in specific indications, in nails and plates and various combinations, everyone was weight bearing from day one. I'll be presenting 4 such cases here. The first one, a really obese lady, osteoporotic bones, and she's an elderly one. That's the position, she's roughly about 138 kilos. There's no general consensus on a dual implant whether to do a nail first or a plate first or a medial plate first. We did it in this way: achieve reduction, do a retrograde nail, then augment it with a lateral plate. In this particular case, the nail and plate were at of the same height, but they were unitized in the proximal, a screw going through the plate into the nail. The patient was mobilized on day 1. At 3 months, you can see her walking, and at 1 year, complete union. Similar case, but here the fracture was quite distal. Hence, the metaphyseal hold was a query, was a question. Hence, we decided to add a third plate, that is a medial to lateral helix submuscular plate. This was pre-bent a day prior and then sent for autoclave. So this pre-bending was done on a sawbone model. Here, there was a long nail and a short plate. The medial helix plate proximal locking was a miss-a-nail technique. This is her at 6 weeks. She's also obese, full weight bearing, and at 1 year, aided walking. What about periprosthetic fractures? Most important is to get the implant details. The notch diameter needs to be known, whether it is a CR or a PS knee, and to have a retrograde nail go through it. So achieve reduction, get the entry point, pass the nail, augment it with a plate. In this particular situation was shorter nail and longer plate. We think that is what a better hold. This is her weight bearing at day 1. Good movement, range of motion at 6 weeks. And at 1 year, unaided gait. What about in a malunited situation? An old malunion with a fresh fracture. 30 years back, he underwent a vascularized fibular graft for the distal femur fracture. You see the proximal, the plate would not sit, and hence we had to do an osteotomy to get the alignment of the limb. But on valgus opening, there was a little movement, so we augmented with a medial to lateral helix plate here as well. At 6 months, signs of union, and at 18 months, complete union. All our patients were full weight bearing from day 1. Average union rate was about 4 to 6 months, and there were no construct failures. Next concern with 2 implants is which implant would fail first. Hence, to increase the stability, we suggest a proximal and a distal locking screw going through the plate into the nail, unitizing both the nails, making it a single unit construct. Several biomechanical studies, including dual plating, dual nail and plate, have said that it is a stronger fixation, it increases stability, especially in periprosthetic fractures, and it reduces the time to union. So my take-home message are these specific indications where you need to consider dual implant fixation in the form of whatever, 2 plates, nail and plate, osteoporosis in obese patients, periprosthetic fracture, a very distal femur fracture, any old malunion, non-union cases, or weaker bones like a poliotic bone or a Parkinson's patient. The benefits is early full weight bearing with dual construct, especially in these particular indications, and it reduces the time to union. We had no construct failures, hence the failure rates we expected to reduce. Thank you.
Thank you. Any questions from the audience?
In a fresh situation, no bone grafting. In the old, no, never. So we are more comfortable with the nail and plate because the nail we get it through a very small incision, and the lateral plate is in a MIPO. Otherwise, for the medial, you'll have to have a separate, larger incision. But the helix plate, we found that even that can be done in a MIPO format. So the lateral plate can be extended to get the proximal and medial small. So nail and plate was our go-to choice because the incision reduced and surgical time reduced. It was more MIPO technique, minimally invasive.
One of the trending treatments now is a distal femur replacement for a very distal fracture in a very obese patient, and you want to make them weight bear early. So do you have any views on this? How you stratify which patient to go for osteosynthesis and which for arthroplasty?
So the pre-walking situation is what we need, the pre-fall, how much the patient was mobilizing and what was the pain status of the knee. The arthritis is evident in few of the patients, but if you do see severe arthritis and the age group it is about 60 to 80, you can go for a distal femur. But we still go for a fixation first and then give it as a
later you salvage it.
salvage.
Fair enough.
Thank you.
Thank you.
Good morning, everyone. My name is Dr. Tanmay Awad. I'm currently a final year resident at Nair Hospital Orthopedics. My topic is uncommon effect of anti-epileptic drugs on fracture union. We generally know that anti-epileptic drugs and bone health tend to have a very complex relationship where anti-epileptic drugs tend to have a very deleterious effect on bone. They decrease the density also and increase the risk of fractures in patients. However, there is very less knowledge regarding their relation with fracture union. We have a case of 45-year-old female presented with pain and swelling over the right arm following trivial trauma at home. She had a history of trauma 1 month ago for which she was managed surgically with plating. She is also a known case of epilepsy on phenytoin and carbamazepine for the last 25 years. Clinical examination were consistent with proximal 1/3 shaft humerus fracture, periprosthetic. The following are the x-rays of the patient. We have another case, 56-year-old female presented with pain swelling over the right arm following trivial trauma. She is also a known case of epilepsy on phenytoin and carbamazepine for the last 28 years. Clinical examination consistent with proximal 1/3 shaft humerus fracture. There is no distal neurovascular deficit. Following is the x-ray of the patient. Both the patients were immobilized with chest arm strapping and planned for surgical management in this condition. Surgical planning was done and routine investigation, blood work was done along with therapeutic drug monitoring, and a neurology opinion was taken. Investigations revealed low calcium and D3 with increased parathyroid hormone and serum alkaline phosphatase, but in the nutritional range. Therapeutic drug monitoring was done to reveal high levels of phenytoin as required dose and attenuation by the neurologist. Patients were optimized in the due course and from anesthesia point of view, and after 10 days were planned for surgery. As per routine protocol, fresh radiographs were obtained. Case 1 post-trauma 10 days revealed exuberant callus formation at the fracture site, and along with case 2 post 12 days also revealed exuberant callus at the fracture site. Clinical improvement in the form of decreased local tenderness and reduced mobility was observed. Patients were then planned for conservative line of management with humerus bracing and metabolic correction. Regular follow-ups were done with serial radiographs and they show good functional outcome and good radiological union. These are the follow-up x-rays obtained, shows good radiological union. This is patient at post-trauma 1 month. Anti-epileptic drugs tend to cause osteoporosis by the following mechanisms. They cause vitamin D3 catabolism, impair the calcium absorption. This is something which we all know. There are certain markers of bone formation such as serum alkaline phosphatase, osteocalcin and type 1 procollagen. These are markers which are seen in high osteoblastic activity in the body. However, these effects of these markers are not seen in a patient receiving AEDs, as osteoporosis is a condition in which bone resorption exceeds formation. But in a condition which, in a fractured state, in a high metabolic state, where the patient receiving AEDs have high levels of bone formation markers as well, and along with the existing body's response to fracture, this has caused synergistically effect in causing fracture union. These are the references for my study. There was a study which was done in 2006 where there was local administration of phenytoin was done in, it's an animal study, where they showed that there was increased mesenchymal proliferation due to phenytoin at the fracture site. However, clinically, the union were at 1 week apart, but after measuring the bone girth of those rats, it was found to be a positive study in terms of positive effect of anti-epileptic round fracture union. Take home message is that this warrants an attention in managing patients with anti-epileptics with or without controlled epilepsy, but displaced fracture deemed unfit for surgery. Such patients can be managed conservatively with supportive metabolic correction. Surgical intervention, if planned, should be done timely to avoid excess malunion or excess callus formation complicating the surgery. Thank you for your patient listening.
Thank you. Any questions from the audience?
Very interesting presentation, and I would like to know if you have had any other patients on any other antileptics which you have compared with these patients as well.
So these two patients were received by us and they were planned for surgery, but being a government setup, it took time for us to get the patient on table. However, when we did get the patient fit for surgery, we ended up finding out that the fracture is united, and we continued
Retrospectively, yeah.
so we continued our line of management. But after which we had an eye for such patient, and we tried to get the patient on table much prior because we don't want, because the reduction is not acceptable. However, the reduction is, so we would plan a surgical intervention on an early basis to avoid that complication thereafter.
So do you recommend screening of drug levels for every patient on anti-epileptics in
Yes, sir.
future?
Therapeutic drug monitoring is a tool which definitely has to be done because patients are generally given phenytoin and they're just given like over the counter in the village part of our city and our country. So I feel that needs to be monitored. There has to be a regular follow-up, which is not generally done in such patients. And the general consensus that it has a deleterious effect is established. It has a bad prognosis. Anti-epileptics,
As well as a surprisingly good prognosis as well.
yes, but yes, it has to be monitored.
Thank you.
Thank you.
Yes. No, sir.
Good morning. My topic is USG-guided PRP injection more efficacious as a treatment modality for lateral elbow tendinopathy than USG-guided steroid injection? Lateral elbow tendinopathy is a progressive degeneration of the extensor tendons at their point of origin. Rather than an inflammatory pathology, it is now considered to be a degenerative pathology. The initial management of this condition includes physiotherapy, ice fermentation, counterforce bracing, and anti-inflammatory medications. The next line of management includes injections of steroids or platelet-rich plasma or autologous blood. The aims and objectives of our study were to compare the efficacy of platelet-rich plasma with steroid injections in lateral elbow tendinopathy over 2 years and to analyze the effectiveness of ultrasound guidance in administering the injections. Our study was a prospective triple-blinded study. We used the consort guidelines and assessed 84 patients for eligibility. 16 patients were excluded for not meeting the inclusion criteria. 68 patients were randomized into groups of 2. 2 patients were lost in each group due to the COVID pandemic, and finally, 32 patients were analyzed in each group. The inclusion criteria for our study was age less than 20 years, more than 20 years and less than 65 years, point tenderness at the lateral epicondyle, persistent elbow pain for a minimum of 3 months, and pain not responding to analgesics, physical therapy, and bracing for a minimum of 6 months. The exclusion criteria included athletes, pregnant females, history of cervical radiculopathy, patients with a history of surgery done for elbow tendinosis, and patients with a known allergy to corticosteroids. 30 ml of blood was drawn for the preparation of PRP in the PRP group. The blood was also drawn from the participants in the steroid group to eliminate bias, and 1 ml of saline and 1 ml of steroid was injected after localization of the pathology using ultrasound. For preparation of PRP, blood was drawn using a syringe preloaded with citrate phosphate dextrose, and PRP was prepared as per the standardized method described in literature. 3 ml of PRP was injected into the site localized by ultrasound. The syringe was covered with a black tape to ensure blinding, and 2 observers who were blinded to the treatment independently assessed the patients for VAS scores, DASH scores, patient-rated tennis elbow evaluation scores, and the hand grip strength. The definition of parameters was as follows. Successful treatment was more than 50% reduction in the scores. Improvement was reduction in the scores up to 25 to 50%. When there was less than 25% reduction in the scores, it was termed as failure. And recurrence was increase in the scores above 50% of baseline any time after completion of successful treatment. The results were as follows. At the initial short-term follow-up of 2 weeks, the VAS scores in the steroid group were better as compared to those in the PRP group. However, at a long-term follow-up of 2 years, the scores were better in the PRP group as compared to the steroid group. The DASH scores and the patient-related tennis elbow evaluation scores also showed similar trends. These graphs show the trends of PRP and VAS scores and DASH scores in the PRP group and the steroid group. In the PRP group, treatment was successful in 31 patients. There was improvement in 1 patient and recurrence in 3 patients. In the steroid group, treatment was successful in 20 patients, improvement in 12 patients, and recurrence in 10 patients. The limitations of our study were the relatively small sample size and the inability to include a control group, as it was not allowed by the Institutional Ethics Committee. Coming to the review of literature, Pierre-Booms et al. Conducted a double-blinded study without the use of USG with a follow-up of 1 year. Gosens et al. Conducted a double-blinded study without the use of USG with a follow-up of 2 years. Gautam et al. Used USG, however, the follow-up was short, that is 6 months. The present study was triple-blinded, it included the use of USG, and it had a long-term follow-up of 2 years. As all 3 scores improved in both the groups, platelet-rich plasma, steroid injections, and the use of ultrasound were associated with favorable outcomes. The symptomatic relief was faster but short-lasting in the steroid group. And the patients injected with platelet-rich plasma demonstrated sustained improvement over long-term follow-up. Thank you.
Any questions from the audience?
Yes, sir, they were painful. We we avoided the use of NSAIDs in both groups as it has a negative action on the platelets, as platelet-rich plasma was also used. So we just used ice fermentation for the initial days. It was painful, but the outcomes were better in the steroid group in the short term. They had better pain relief initially, but then they showed recurrence in the long term.
I found that your inclusion-exclusion criteria don't mention diabetes or pre-existing polyarthritis. So were there equal amount of polyarthritis in both groups?
So, yeah, that was done as per the randomization. So
you found identical outcomes,
yes, sir,
regardless
yes, sir.
of the patient is a rheumatoid patient or not?
Yes, sir. Yes, sir. That's why we did not include them as the exclusion criteria.
Okay.
Did you also try for the papering technique?
So peppering technique was not used in this study. We used ultrasound guidance because earlier studies had used peppering technique. So we just used guidance injection under ultrasound after localization.
Okay. Thank you.
Thank you, sir.
Please collect your certificate.